Howdy, y'all. I'm Dr. Jeff Jarvis back with another PRM. Now, I got to get this out of the way. I'm recording this in spring, and y'all know what spring brings. That's right, baby. Baseball is back. Now, first things first, congratulations to the Texas Rangers on winning the 2023 World Series. I'm a fan. It's, hometown team. I'm a fan. I'm wearing my Rangers hat to celebrate, and it's not just because I lost a bet with Buck. But y'all, I'm from Houston. I grew up in Houston. I grew up an Astros fan. Hate me if you will, and I know you do. But you gotta pull for your team. Seriously, how can you respect someone who doesn't stick with their team? Now, with that important announcement out of the way, let's talk termination of resuscitation, shall we? I think we shall. Transport of cardiac arrest patients without ROSC is almost uniformly futile for the patient, and it's dangerous for us. It increases utilization of healthcare resources in the hospital, and it falsely raises family hope. Outside of patients who lose pulses en route, those in persistent shockable rhythms, and some very rare other conditions, we should expect to either transport after ROSC or, in the absence of ROSC, to terminate arrest in the field. Now, that includes pediatric patients and those in public spaces. Rapid transport with CPR in progress actually decreases the odds of eventual survival in both adults and pediatric patients. I want to say that again. Rapid transport of patients, including pediatric patients, without ROSC decreases the chance of survival. The best thing we can do for these people is stay on scene and work the resuscitation. We have several papers now that show this. When we just throw them in the back of the truck and try to resuscitate en route, we are almost always doing it for our benefit and not the patient's benefit. And futile transport doesn't benefit the family either. What benefits the family is continual communication, setting realistic expectations early on in the resuscitation, and providing ongoing explanations for what we're doing, why we're doing it, and how it is in the patient's best chances of survival, because it is the patient's best chance of survival. Now, we'll provide a demonstration of how that conversation can go at the end of this review. So, one big change we need to make is who performs the termination. After a careful review of Texas state regulations, it turns out that it needs to be a physician. We can't do it by protocol, despite having done it for so many years. I know we've been doing it, but it turns out the law has said we can't. Now, we often do things because we don't realize that they're not kosher in law, and this is one of those examples. This means that all terminations done must go through OLMC and one of the docs. To be clear, however, you only need a termination of resuscitation if there actually is a resuscitation to terminate. If you determine any resuscitation would be futile and you withhold care, that's a different thing entirely. You don't need a doc for that. Please go right on following the withholding protocol without calling. More on that in the withholding PRM. Now, it's important to understand that medical and traumatic arrest are two completely different animals. What works in one doesn't work in the other. Epinephrine and CPR, for example, are next to pointless in trauma. Now, because of this, it doesn't make sense to give epi and require 10 or 15 minutes of CPR before requesting termination of a traumatic arrest. We just need to do the things that can make a difference. And if they don't work, we need to recognize futility and assure we are caring for family and bystanders as best we can. Medical arrest, on the other hand, they have more things like good CPR, effective CPR, early defibrillation that can and do work. These patients, they deserve a full resuscitation before termination. Now, what the resuscitation looks like for these two types of patients, it's covered in the medical and the traumatic arrest protocols, but I'd like to go over the things they have in common regarding termination. We're going to start with trauma because it's pretty simple. First off, there is no minimum time we must attempt resuscitation. Just do the things that can make a difference. If it doesn't make a difference, call for termination. Refer to the traumatic arrest protocol for full details, but this basically means that we need to assure effective ventilations. We need to decompress any potential tension pneumothoraces, or, now this is only after the trauma arrest protocol rolls out later in the year, do a pericardial, if there is pericardial tamponade, deal with the pericardial tamponade. If there's bleeding, stop the bleeding, put pressure on, put tourniquets on, and then do one last check for anything we may have missed that might be reversible. If you don't see anything, there probably isn't anything. Ongoing CPR isn't going to work. If you don't see anything, call for termination. Surgery in these patients, it's not going to be helpful unless the patient happens to code in the trauma center parking lot or as you're approaching it. No epi at all is required. And let's think about this. If you go into cardiac arrest because of a tension pneumothorax, epinephrine can't decompress a pneumothorax. If you go into cardiac arrest because of an obstructed airway, epinephrine can't fix the obstructed airway. If you go into cardiac arrest because your last red blood cell just went out onto the ground, epinephrine is not going to transport oxygen. It's not going to help stop bleeding. Again, more on this when we roll out the traumatic arrest protocol. Just know in trauma, no time period. When you've done the things, call. Now for the medical arrest. CPR matters greatly for these patients, and there is a lot more we can do. And depending on how the patient responds, we do need to attempt resuscitation for a minimum amount of time. Now, assure that you have accomplished or at least attempted everything in the medical arrest protocol, including assuring effective oxygenation and ventilation, establishing IV or IO access, and giving appropriate medication. Address everything you can think of that is addressable, and then give OLMC a call. Now, here are some guidelines on when to call based on the end-tidal CO2 levels. These are just guidelines. They're not exclusive. If you think there is a reason in this call that you need to call earlier for termination, then go ahead and do it. The worst thing that can happen is we say, no, we need to continue resuscitating a little bit longer. Now, back to end-tidal CO2. There are some general guidelines based on what we know about end-tidal CO2 in the literature. If the end-tidal CO2 is less than 10 after the first 10 minutes, give us a call because that is almost uniformly fatal. If it's 10 or higher after the first 10 minutes, keep going for another 10 minutes. If the end-tidal CO2 is greater than 10 but under 20 after 20 minutes, go ahead and give us a call. Otherwise, keep going for another 10 minutes. And then after 30 minutes, give us a call. Now, the one exception to this is persistent VFib. That still needs transport. Now, here are some of the things I consider about end-tidal CO2 in arrest that led me to create those guidelines. First, end-tidal CO2 is going to go up for about 5 to 10 minutes following bicarb, regardless of whether you get pulses or not. It's just physiology. It's the carbonic acid reaction. You give the bicarb combines with hydrogen, forms CO2 and water, and you got to breathe that off. Just know that takes a little bit. Just expect it. If the end-tidal CO2 shoots up, confirm there's no ROSC at the next rhythm check, but don't be surprised if it isn't there. Bicarb does that. Expect it. Next, low end-tidal CO2 after sufficient resuscitation, say 10 minutes, is highly predictive of futility. we have the best evidence surrounding this. Everything else about end-tidal CO2 is much less certain. With good CPR, for example, patients can have very high end-tidal CO2 values and still not survive. Transport for high end-tidal CO2 values alone, meaning regardless of what else is going on in the arrest, is not indicated. Let me say that again. Transport is not indicated solely because of high end-tidal CO2 values. Those have a very poor predictive value. We just need to take it as one more data point in the mix that we consider when determining prognosis. Now, when you call OLMC for termination, please use the template that we're providing you. I performed hundreds of field terminations. I was on call for the last 11 years all by myself and did all of the field terminations. I did these with a wide variety of clinicians, and my experiences ranged from perfection, immediate understanding, to asking 15 times for clarification and still not understanding what the medic is trying to tell me. This is one of those high-risk communication types that we really need to focus on relaying the vital information, only the vital information, and in the expected order so that we can better understand it. So please follow the template. The doc's going to listen and then repeat back what they heard for closed-loop communication. The template helps make sure this goes as quickly and as smoothly as possible. The items in the template are in the protocol, but here's an example of what that ought to sound like.
Howdy, Doc. This is Jeff on Medic 43. I'm currently working a medical arrest and am calling for a termination of resuscitation. I have a 68-year-old male in a private home who has terminal cancer but no DNR. He had an unwitnessed arrest with an estimated 30-minute downtime without bystander CPR before fire arrived. The initial rhythm was asystole, and it has remained asystolic despite epinephrine, an epinephrine infusion, bicarb, and 20 minutes of pit crew resuscitation. End-tidal CO2 was 30 immediately after placing the supraglottic, and now 20 minutes after resuscitation, on our monitor it's 15. We never had ROSC, and I would like to request termination.
So that's it for termination. Let's go over the big takeaways. Number one, termination needs a doc. Cannot be done anymore by protocol. It's just not the law. Withholding resuscitation, on the other hand, can be done by protocol and does not need a doc. Next, trauma has no minimum duration of resuscitation. Get the things done and then call. Medical arrest will require at least 10 minutes of resuscitation, plus the things in the protocol. If end-tidal CO2 is less than 10 at 10 minutes, call a doc. If it's 10 or higher at 10 minutes, continue resus for another 10 minutes. Then, if it is under 20 at 20 minutes, call a doc. Otherwise, continue for 30 minutes before calling. Now, we are highly unlikely to grant a termination request for persistent shockable rhythms, but we will absolutely consider termination for patients who had a shockable rhythm and then converted to a non-shockable rhythm and have been in a non-shockable rhythm for a while. Same thing goes with transient ROSC. We may terminate a patient who got epi and then had brief ROSC and now has been pulseless for some time. So when it comes to terminations, we've already determined that we can't offer the patient anything further, but we can and should continue to support the family. I mentioned the keys to helping them are early and ongoing communication, setting realistic expectations early in the arrest, and then keeping them up to date on what's going on. Speak plainly to them and avoid medical jargon, but be clear. Don't say your loved one has passed, say they have died. We're going to do another video with some examples and a little bit more information, so look for a family death notification PRM. All right, guys, that's it for termination. Thanks for watching, and thanks for what you do for our community every day. Take care, y'all.